Thank you, everybody, and welcome. Just want to say we had a bit of delay starting. We just did a bit of sound check, and we had some of the inevitable sound issues, but those are all resolved. So we're quite pleased to be here today, coming here from the Squamish territories in West Vancouver. And as we have each of our speakers, they'll indicate the territory that they're coming from. But I'm very pleased that we have Dr. Shannon McDonald, our acting chief medical officer, Dr. Nell Wyman, our acting deputy chief medical officer, and Dr. Becky Palmer, chief nursing officer, as well as Chuck Wilmink, who's been instrumental in our logistics. So we'll start with some brief opening comments, and then as indicated, we'll follow a round of questions, and we'll try to be efficient about that, and we will conclude in 1 hour. So I would, without further elaboration, I'll go to Dr. Shannon McDonald for some opening comments.
Thank you, Richard. And I'm coming to you today from Sayut First Nation, where I'm honored to live as a guest among the Wasanic people on Vancouver Island. We've been busy, and I really appreciate the interest that media has had in our time and attention and hearing our news, but the challenge has been fitting your needs in among the needs of our communities, and understandably, our communities take priority in that. So this seems to be the most efficient way to have conversations. We are coming up on a year from the time when we had our first identified positive COVID case among First Nations in BC, and as of yesterday, we have exceeded 2,500 cases in that period of time. It has waxed and waned throughout the year, but very recently, especially in the last couple of weeks of the new year, we have seen significant increases in the number of positive cases in communities. Previously, our ratio of on reserve, off reserve was much lower, about 25% on reserve. But now we're at about 40% of cases being identified in community, and we've had some significant clusters, which I'm sure you've heard. Our work right now is around the 600 active cases out of that 2,500. We sadly have had to report our 32nd death among our citizens, and recognizing that those are people and not just numbers, and our communities have really struggled to deal with the losses, and in some communities multiple losses, and so I want to acknowledge that. Vaccine has been a really exciting development in all of this. We have been working very hard to maximize the number of communities for whom vaccine has been available. We have developed prioritization based on remoteness and whether or not communities have experienced clusters and losses. It's been a difficult process, but it's one that we're confident in. We have worked very hard with regional health authority partners who, in addition to the allotments we've had from the province, have added to those allotments and have recognized the needs of First Nations among the citizens within their territories. And we've worked to collaborate on developing processes for vaccine delivery in community. As of this week, we have 19 communities in the province who have received vaccine or are in the process of receiving vaccine. And by the end of next week, we will be closer to 60 communities who have had the opportunity to receive vaccine. But the vaccine is not a panacea and it's not magic. We know, for example, that upon receiving the vaccine, an individual can take around 10 days to develop immunity. We do not know yet whether people who have developed immunity can still carry the vaccine and potentially infect other people. The science hasn't confirmed that yet. So some of the messaging that we've been struggling to give is that once you get the vaccine, it's not the ticket to gather, it's not the ticket to let go of the public health guidelines that you've been given. So we continue to work with communities on making that happen. I really appreciate the participation and enthusiasm shown by community level staff and our own teams. It's been a significant effort, and that work continues and probably will continue for some months to come. So thank you.
Thank you. I'll now turn to Dr. Nell Wyman.
Great, thank you. Good morning, everyone. So my name is Nell Wyman. I'm the Acting Deputy Chief Medical Officer here at FNHA, originally from Little Grand Rapids First Nation in Manitoba, but I live as a guest on Coast Salish territory, and I'm happy to join you today. I'll try to keep my comments really brief and follow up on what Dr. McDonald has mentioned around some of the work we have done, not just in delivering vaccine to communities, but trying through our communications to develop, to build vaccine confidence so that we're framing it against vaccine hesitancy. We're talking about building vaccine confidence. And you will see for yourself if you check out links on our website to some of the stories around communities who have already received the vaccine. There's some amazing photos of the vaccine arriving in community and being greeted with ceremony. And one particular video of a 94-year-old elder who was the first recipient in her community to receive the vaccine. So hopefully you can see those resources. And I just want to comment, because I'm a psychiatrist originally by training, we are also focusing on some of the mental health and wellness aspects of the pandemic and in the vaccine rollout. So for example, we have lived for about a year with the uncertainty of living in a pandemic. We don't know exactly when this is going to end. And there's a lot of feelings that people have a loss of control. We can't necessarily control in what order we're going to receive the vaccine, for example, as individuals. So there is a great deal of reassurance that we're trying to convey and encouragement to communities that, as Dr. McDonald mentioned, once you are vaccinated, that doesn't necessarily mean that you can just go back to living your normal life, that you still have to adhere to the public health measures. And for those who are still waiting for that vaccine, we are encouraging calm and being kind to one another. On that note, FNHA is also continuing its work in other pillars, including our response to the opioid crisis, which intersects with the COVID pandemic, and our ongoing work in anti-Indigenous racism. So I'll stop there and hand it back to Richard.
Thanks, Drs. McDonald and Wyman. I'll now turn to Dr. Becky Palmer, our Chief Nursing Officer, for comments.
Great. Good morning, everyone. Thank you for joining us. And thank you to Dr. McDonald and Dr. Wyman for your comments as well. I too will keep my comments brief and just signal a few things echoing my colleagues' comments. We'll continue to work in partnership with our communities directly, as well as continue to sit on the federal tables, the provincial tables, the regional tables, and along with our communities to continue to advance our work in implementation and rollout of the vaccine. Through that, we've been taking a very intentional and very mindful approach, leveraging the strengths of community and the resilience of community in our approaches. and really leveraging the great work that's been done in previous flu campaigns, as an example, leveraging the skill set and enthusiasm and passion of the care teams that are working alongside community members in the rollout of the vaccine. And really through that, signaling tremendous partnership with our regional health authority partners as well, alongside community. We are capturing any of the learnings that we have as we move through this and the logistics to help continue to support a very seamless and successful transformative work across the province as we roll out the vaccine. And in the background, all of the clinical work being done to ensure that all of our nurses and other care professionals, have all of the competencies required as they do for a successful rollout as well. So again, the vaccine first landed in our most rural and remote settings on December the 29th. And since that time, we've seen incredible collaboration, partnership, learning, resilience, and as Dr. Wyman alluded to, the just brilliant, heartwarming stories coming from the voices of our people sharing the good work. So I will stop there. I look forward to your questions. Thank you.
Thank you. And as I mentioned earlier, Chuck Wilmink is also on the line, as is our VP of Community Health Services, Sonia Isaac Mann. They will be available to serve as resources for questions as relevant. So we will proceed quickly to those questions. And we'll start off first with Angela Starrett.
Hello, thank you so much for taking my call. Can you hear me?
Yes.
Mhm.
And I know I'm only allowed one question. I have a couple, but I'll stick to one. We know that the First Nations Health Authority released some data for the first time since the pandemic last month. What was behind this decision of why you decided to release those numbers to the public? And why are they still limited?
Shannon?
Oh, okay. Hi, Angela. Good to hear your voice again. Early on in the pandemic, one of the concerns that we had was the risk of re-identification of individuals or singular communities in terms of positive cases. We've seen recently some of the challenges around the rise of racism, anti-Indigenous racism related to those identifications, and even to make sure that communities had what they need to be able to respond. We were concerned, for example, when we started to release the vaccine, that identification of communities might mean that people would travel to communities to attempt to receive vaccine, that others, including media, might be interested in going to community to get a story, but in doing so would break through the barriers of limited access to communities that many communities have put into place to protect themselves. So it's been a discussion with our communities. And the other story I think that's important is that these are the stories of those communities. And if the communities decide to share them publicly, that is their prerogative. It is not necessarily ours to speak on their behalf.
Becky, would you like to add comments?
Nothing further to add on that one. Thank you.
Dr. Wyman, you want to comment a bit on some of what we're seeing in terms of some of the backlash we're experiencing?
Thanks, Richard, and thanks, Angela, for the question. Yeah, just in terms of providing more kind of context, I think what we have seen, for example, in one region of the province is when it has come to public attention that there is a current cluster, that there has been a lot of racism infused backlash against some of the members of that community. And so we really, obviously we find this to be completely unacceptable. And we have been working with both our, regional FNHA teams and the leadership of the communities on how we can address that. And they have themselves reached out to sort of some of the municipal leaders in that area to speak out against racism in those instances. So, we are trying to address it, but, it would be quite a different sort of conversation to talk about how we are responding to anti-Indigenous racism provincially. But that work is still also being done concurrently. Thanks.
Thank you. I'll go next to Lisa Cordasco.
Thank you very much for taking my question. Could you please describe the process or, the role, at least, of the First Nations Health Authority in deciding to, divert vaccine to the Snuneymuxw First Nation and to the Cowichan tribes?
I can take that.
Go ahead.
As a matter of fact, the decision to divert vaccine to Snuneymuxw First Nation was done primarily with the leadership of the Vancouver Island Health Authority. We were aware of that decision, and it has in some ways been challenging because normally vaccine is not meant as a treatment or a response to an outbreak, but a preventative. And it's a really different way of thinking. So we've continued to work with Vancouver Island Health Authority around the cluster in Snuneymuxw. And now the regional team is working with Vancouver Island Health Authority when they released some of their allotment to serve the needs of Cowichan tribes. We've been very challenged in our ability to access vaccine. We have shortages when we compare our priority lists to what's been made available at this point from the province or through our partnership with regional health authorities. But we're not alone in that. All of the regional health authorities are expressing the same concern that the access to vaccine is limited and our ability to respond can sometimes appear limited. But in reality, the focus of a vaccine program is prevention, not response. And we've been very clear about what our priorities are for provision of vaccine, primarily at this point to our most remote and isolated communities, and moving inward towards communities that have greater access to healthcare services.
I would add that this is an evolving circumstance, and that some of the learnings and so on that are occurring are incremental. So as we have gone forward, then some of the developments are also things that we're learning from going forward. As Shannon has pointed out, what happens is if there's advocacy, that's certainly important, but what it results in is that that the supply is limited, so therefore that results in there being choices that have to be made. So I would say at this point, part of what we've learned is that we need to stay with our priorities, that we really do the job, especially on the remote and isolated communities first, in order to minimize those risks. So it is a learning process, and I would say all of the provinces are going through similar learning provinces, as are we. So next I'll go to John Hua.
Yeah, can you hear me? This is John Hua with Global News. So just wanted to have a follow-up question in regards to the backlash of racism and discrimination to the FNHA, trying to be transparent about clusters and exposures. We know that some community leaders have said that, in those communities where they're facing that discrimination, there are exposures and closures there, but it may not be as much of a common knowledge because what the health authorities or maybe even the Ministry of Health aren't being as transparent as the FNHA. Is there a discussion to maybe kind of even up the playing field so people just are more aware that this is a common occurrence and it is not coming from just the communities of the FNHA?
I'll go to Shannon and Becky, then over to Nell.
We have no control over what the province or the regional health authorities report publicly. But we do know, and we've seen, every day, Dr. Bonnie Henry is before the media talking about the number of cases, the risk in community, and the increasing challenges. The detail of the local appearance of COVID cases has been less frequently reported, and that can be a challenge. But for example, the conversation that has been going on for some time now about schools, I often tell families and communities that the COVID monster isn't hiding in the closet to jump out and attack a child as they come into the building, that it's being carried in by children who bring, or teachers or staff, who bring that infection from their home and from their community. So the risk is only reflective of what's in the community. And I think in cases, with the possible exception of extremely remote communities where individuals have traveled in and out from non-Indigenous communities, the transmission has been universal. It's everywhere in the province. And we often tell people to be conscious that everybody is a potential source, and therefore the public health response activities like washing your hands, like wearing a mask, like social distancing are important no matter what context you're in. So would it be helpful to know exactly where every case is? Probably not. The challenge for us is that our population is quite visible within general populations in communities, and therefore the fear and anxiety that people may feel about COVID can trigger First Nations people being targeted with that fear and anxiety and resulting in racist behavior. So it's challenging, but I don't think it's as simple as reporting them on local cases.
Becky?
Thanks, Dr. McDonald. I think I would just add to that very comprehensive answer is, we know that COVID doesn't stop at a doorway and doesn't knock to come in when it's invited. It's everywhere. And so we are continuing and will continue to reinforce the messaging around the public health measures, no matter where you are. And incredibly important that, that is a common experience and accountability we all hold around adhering to the public health measures. So we're just keeping strong in that messaging, and also keeping strong in the messaging around what is personal, private medical information is held by that individual. And as a healthcare professional, we're not at liberty to share that individual information as well. So that's just important information that and a code of ethics of healthcare professionals to maintain. But picking up on Dr. Wyman's earlier comment in opening comments is, we absolutely do not tolerate any anti-Indigenous or racist behaviors. And so, again, we're reinforcing the public health measures across the board. And not tolerating any of the others' behaviors. Thanks.
Thanks. Dr. Wyman?
Thanks. I'll just be brief and add on to what's already been said. Is, I think, the racism that's experienced is you know, as Dr. McDonald mentioned, is probably not related only to a particular release of data. It probably speaks to existing tensions that have been around and relationships between different communities for a long time. And it's the pandemic which puts these types of strained relationships into high relief. So, you know, the work that I mentioned, you know, we have to keep working on anti-Indigenous racism because things like the pandemic actually put some of the disparities into focus. And as Dr. Palmer mentioned, you know, and as was mentioned in the recently released In Plain Sight report, what we have to do is work on creating a culture of zero tolerance for anti-Indigenous racism and indeed racism of all forms. And be able to move forward in a better way. And I think, you know, Dr. Bonnie Henry has spoken so often in her news conferences about being kind to one another, and you know, that sounds kind of aspirational, but that's partly what it really comes down to is, you know, we're all in this together, and we're going to have to move through this together. And there's just no place for racism in anybody's response to the COVID pandemic.
Thank you. I'll go to Denise Tidian.
Good afternoon, and thank you for taking my question. This is Denise Tidian from Hoshosa newspaper. With more than half of BC's Indigenous people living off reserve, how and when will the vaccine be delivered, in what order? To the people off reserve, sorry.
Thanks. I'll turn to our panel, starting with Dr. McDonald.
Thank you, Denise, and welcome back. I think the challenge in this picture is that we don't have service responsibility for health services to First Nations people off reserve or away from home, which is the term we prefer to use. Many of our communities provide service to their members, no matter where they live. And so depending on communities where housing might be limited or employment might be limited, there are, excuse me, individuals who may be living very close to home, but not at home, not on the reserve, and they may be included in plans for a particular community. But for those living further away or in urban settings, it is a matter of partnership with regional health authorities. We would not be directly providing those vaccines, but we may be participating in partnership to make sure that the distribution is done in a culturally safe and accessible way.
Dr. Palmer, would you like to add any comments?
Sure. Thanks for the question, Denise. Reinforcing Dr. McDonald's response to that, we are working and at the table along with our regional health authority partners where we know our Indigenous populations are identified as a priority. So working alongside them to help support the planning for clinics that would fall under the regional health authority accountability.
Dr. Wyman?
Thank you. I think the only thing I would add, you know, is one of our roles here at FNHA is also to do advocacy. And, you know, Dr. McDonald, Dr. Palmer, and myself are involved in various, not just regional or provincial tables, but sit on some national tables that have to do with vaccination. The discussion around vaccination of urban Indigenous people or away from home, you know, has been highlighted in those discussions. So, you know, as Dr. McDonald mentioned, we may be in discussion with our regional partners around that. But certainly we are strongly advocating, and we have, for all Indigenous people to be vaccinated as part of a priority group.
Thank you. I'll go back to Angela Starrett. You had said at the outset you had a couple of questions. Would you like to ask a second question?
Yes, just give me 1 second. So yeah, it's back to the question about racism and data. I know, Dr. Nell Wyman, you said that this is not about the lack of data in towns and cities, non-Indigenous towns and cities, but none of the communities that I spoke to spoke about there being tensions before. In fact, a lot of the communities were quite close, and this has really kind of uplifted something that wasn't there. So I guess my question is, we are hearing about Indigenous people across the province not allowed in restaurants, in grocery stores, from communities that again have been very transparent about COVID-19 cases. Leaders, this is including Indigenous leaders, mayors, and others that I spoke to said this is because of the limited data we have about COVID-19 in those non-Indigenous towns and cities. Yes, we have some of that data now, but do you agree, or what do you say to those strong, large number of people who say this is about lacking data and this is creating actually tension that was not there before? And how will you address that? And thank you very much for taking my question.
Okay, we'll start with our panel, Dr. McDonald.
I was going to pass it on to Nell because that was directed at her to a certain extent. But my only comment would be that the racism has always been there. And sometimes it simmers very close to the surface, but isn't as evident or publicly acceptable. But in a time of stress, those things can arise. So I'm not sure data is the only consideration here. Nell?
Actually, that was going to be my response, actually, and I probably should have been clear when I stated it, that the tension that I was referring to is probably always under the surface, but as Dr. McDonald just mentioned, this is an example of a stressor that brings things into relief. There are a lot of factors that play into racist behaviors, and racism toward First Nations individuals from certain communities during the pandemic, didn't just arise because of the pandemic.
I think it's important to clarify that some of these public releases are not done by FNHA, that they're done by Facebook or other social media, and it's not actually FNHA that's releasing this information. So I just wanted to clarify that because we don't go out with public notifications of where cases or clusters exist. So once it's in the social media, then of course, then that's a completely different circumstance. And the experience has been fairly common right from the first outbreaks right to now. So I wouldn't say that this is a recent development, but I would turn to Becky and our panel to make further comments on that. Dr. Powell?
Yeah, I would just reinforce what's already been shared, which is to say that I don't think that this is a new experience. I just think it's being verbalized. I think it's always been there. And so, in front of us is an opportunity to continue on the work that we do in anti-Indigenous racism. And ensure that it's not acceptable. Do our best to ensure that it's not acceptable and model the way around that. But in terms of thoughts around, is it new or specifically related to data, as my colleagues have said, probably not.
Any other comments? I think the other thing I would say is there's some good practices that are also emerging where communities are having conversations with local mayors and so on, and that seems to be an effective approach, and also some championing of local municipal leaders against racism. So I think it's also fair to say there's some mixed responses to the racism and some good practices that are emerging. So go next to Lisa Cordasco.
Thank you. I'm sorry I didn't introduce myself the last time. I'm with CHLY, which is a campus community radio station in Nanaimo. I wanted to just delve a little bit deeper into the comments you made about advocating for First Nations members who do not live at home, to get the vaccine and in what order of priority. Are you not, do you not have faith in the system of how Dr. Bonnie Henry and the team, the rollout team, is going to prioritize? Like we know already that in the next group, it will be seniors living in, outside of care homes who will be on the priority list for the next group ahead. So again, seniors, it doesn't matter what race, all seniors will be covered in that. Next after that will be healthcare workers, homeless people, and marginalized people who live in group homes, followed by people who have underlying medical conditions that put them more at risk. Are you not satisfied that in that sort of hierarchy of people who will get the vaccine, that somehow First Nations members will not be included?
Thank you, Lisa, for that question. We have a very, very strong partnership with the provincial health officer and with our regional health authority partners. And we actually participated at the tables where decisions were made about those priorities. So are we confident in them? Absolutely. The biggest thing that we have been able to influence is that the original identification of individuals, elders over the age of 80, was a bit problematic for our populations because there aren't that many Indigenous people over the age of 80. And so we have strongly encouraged health authority partners and ultimately seen a change in provincial prioritization that would identify First Nations and Indigenous people over the age of 65 as being on the top of that priority list. So it's just a matter of our awareness of the population we serve and being able to work with our partners on adjusting it to assure that our population will be well served among those priorities.
I would ask our panel also to comment as well, though, because we have adopted a whole of community approach because of the unique and special characteristics of First Nations communities that make especially remote communities more at risk. And I would point to some of the Manitoba examples of where that can get out of hand and really say that's reflected in our approach. So could you comment on that, please, Dr. McDonald?
I think that we're really talking about different things here. Our prioritization and our concern, especially about remote and isolated communities and communities where access to secondary level healthcare, hospitalization, et cetera, play a role. So we've been very interested in whole of community approach. When we look at households, for example, just going in and vaccinating the elder really wouldn't consider the other number of people or multi-generations that may share a home. There's a lot more collectivity, shall we say, in many of our communities. But in the urban settings, there are challenges, and because we are not the primary provider in those communities, our role is advocacy and not control. Becky?
Yeah, thanks, Dr. McDonald. And I would first reinforce sort of the earlier part of the question was really around our relationship and trust in our partnership. And I would echo the comments around having a very positive relationship with both the Provincial Health Office as well as with our Regional Health Authority partners. So definitely feel like, we are partnering well in that regard, and we're at the tables we need to be at, which I think is the important piece. So signaling that first and foremost. To Richard's point around our philosophy around a whole community approach, I think that's been a really powerful concept and methodology by which to serve all our people. And, you know, knowing that in the areas in which we did have the responsibility and accountability for service delivery is, you know, really working from our rural, remote, isolated settings in and recognizing, and we're really heard in our advocacy around this, that that whole community approach really honored and respected the teachings and the ability to provide a, you know, full service, if you will, immunizations should people choose to get vaccinated. And what we're learning from that is well received. We know it's a way in which we can best protect our elders is through that whole community approach. And I think that that's one of the really innovative ways we're going to be able to continue to support the health and wellness of all of our communities across the province moving forward. Thanks.
Anything to add, Dr. Wyman?
Yeah, thanks for the question. I think, and to clarify, you know, many of us here who work in leadership positions hold different hats at the same time. So I think maybe to clarify what I said earlier, one of the other hats I wear is as president of the Indigenous Physicians Association of Canada. And so, you know, when the vaccines were starting to become imminent in terms of their approval and distribution, you know, members of our organization who frequently advocate for, you know, for First Nations, Métis, and Inuit communities were involved in discussions at higher levels than provincial levels, like the national level, for example. So for myself, it wasn't at all a critique of our current relationship at FNHA with our provincial partners. It was that we wanted the work early on is we wanted to advocate strongly for Indigenous people to be included in those priority groups. You know, the notion of on reserve and away from home in some ways is very blurred because that's where a particular person has their address, but there is a lot of mobility. We are a very mobile population in some instances, and not just in British Columbia, but across the country. And there are places across the country in some larger cities where certain sections of the city are considered to be urban reserves. And so we wanted to advocate for all Indigenous people to be considered in the priority group for vaccination. The other issue is, you know, we wanted to combat early on some of the comments that we were seeing being made by leaders in other areas of the country. For example, you know, this again is where the racism piece comes into it, where we were hearing, you know, provincial leaders say things like, you know, by giving vaccine to First Nations people, that would be taking away from regular members of a particular province. And, you know, so it's, you know, even though we are working, you know, our focus here at FNHA is on the BC provincial situation, some of us just can't help, you know, we are involved in other ways in what's going on across the country. And I think that's where my comments came from. Thanks.
Thanks. So I'll go to Arthur Williams.
Sorry, I was just unmuting there. Thank you. And I apologize if this question ties into information that was released in the beginning of the press conference here. I was having some audio troubles, had to switch devices to get the audio, but I was just hoping to get a sense of, you mentioned, you know, hoping by the end of next week to have it rolled out to 60 communities. What is the scope of this project to get, you know, all First Nations communities in BC vaccinated? How many communities, how many individuals, and you know, how, I guess, what's the timeline look like to do that?
May I, Richard?
Certainly, please.
In working with the province, there is a recognition that We have 203 First Nations communities in the province and about 55,000 people who live on reserve, more or less, over the age of 18. So the commitment from the province to us is that there would be sufficient vaccine made available over the period of time where vaccine is being distributed, to give vaccine to everybody that wants it, an immunization. So ultimately, all of those communities will be served according to the priority list that we've already talked about. And we will be working closely with the regional health authorities to make sure that happens. And we continue to sit, as was said, at federal and provincial tables to assure that the vaccine supply will be sufficient, that supplies will be sufficient, and that everybody that wants a vaccine will receive one. Dr. Palmer?
Thanks, Dr. McDonald. The only thing I would add to that, and thanks for the question, Arthur, is you asked a question around when. And that's really contingent upon the availability of vaccines. So, that is a global conversation, certainly a national conversation and a provincial conversation. So in terms of the commitment that all of our members would be receiving vaccines who choose to receive them, absolutely. The timelines around that is really contingent upon the availability of the vaccine. So, and as Shannon said, Dr. McDonald, we do have our prioritization lists and working alongside the province and the regional health authority for our away from home populations as well. And I think, quite frankly, the sooner the better. So as it's available, we'll continue on with our streamline efforts. Thanks.
Okay, thanks. We'll go to what we'll call the lightning round of our questions and responses so that we can conclude. So I'll go to Bailey.
Hello, yes, hi. My name is Bailey Morell. I am with Indigenews. My apologies again if this is a restating of an earlier question. I also had device issues. I guess I just have a question here from my colleague Odette, who I am doing some interviewing for her. She's wondering what the state of vaccine misinformation is in First Nations communities and if you folks are addressing it, if that's an issue.
Okay,
Wow.
thanks. Let's turn to our panel. Go ahead, Dr. McDonald.
Vaccine misinformation is everywhere. Disinformation is everywhere. And social media is full of it, people full of it in more than one way. Sorry, inappropriate. Our best tool is communication. And we have been doing that in person. We've been doing it on a significant number of webinars where, including this afternoon, where we're available for First Nations community leaders and providers. We have spoken to people individually. We have done what we're doing today. We have made as much information as possible available on our website for people and have posted all the frequently asked questions from the webinars. This is a matter of trust. And that's one of the biggest challenges that we have come up against. Communities do not universally have trust in the healthcare system for lots of different reasons in history. There is a long-standing issue of misinformation around vaccines. And there is some challenges to understanding the technology of the mRNA vaccine versus what we've experienced in the past. So our role is to communicate, and provide as much information as possible so people can make informed choices about whether or not they accept the vaccine.
Thanks, Dr. Wyman. I know you have strong thoughts on this.
Thanks, Richard. Yeah, I mean, I think the only thing I would add around, the sort of communication and getting the message out there is that we do as Richard mentioned at the very beginning, this is the first time we're doing something like this. This is the first time any of us have lived through this pandemic. But what we are doing in terms of communication to combat misinformation and build vaccine confidence, as an example, is our different FNHA regions are also sharing learnings with each other in terms of what's going well in communities and how the message, the accurate information is being spread. From the Office of the Chief Medical Officer here at First Nations Health Authority, we are committed to providing accurate information from which people can make an informed decision for themselves as individuals as to whether or not they choose to have the vaccine. And lastly, what I would point out is, some of our BC communities, First Nation communities, are putting out their own stories of their experience during the pandemic, but particularly their experience of the vaccine coming to those communities. So again, I would, refer you to check out some of the stories, not just on our website, but I think they're referenced on our website, that just show some of the positive messages that have come out. Like, it's really hard to put into words how moving some of these pictures and videos are. And you can tell how grateful the people that live in those communities are. We, as Shannon mentioned, we have to be professionals, but we're living through this pandemic too. And when you sit on a teleconference with a community that's just been vaccinated, it's very hard to not, feel like incredible happiness and a bit tearful at the same time, because it's so moving. So that's the only other thing. And I think the last thing, sorry, I can go on and on, is, our Indigenous health leaders need to also be examples, so providing good, accurate information. And where it has been possible, some of our, for example, Indigenous physicians have been vaccinated already in different places across the country. And so we are encouraging them to share their experiences on social media to serve as sort of, good role models or influencers. Thanks.
Thanks, Dr. Palmer. I know you have a couple of good examples.
Yeah, so I'll be brief, but just to pick up on Dr. McDonald's earlier comment too around engagement pathways. So, we have the table set to have those conversations alongside our communities, really robust engagement pathways. And I think the other piece I would add to that is, and a real strength here, is the relationship that has been built over time with our care professionals and our care teams, along with community members. And so really building on that relationship piece, building on the trust component there. We're seeing some tremendous examples of where we have communities partnered with their care teams to have, what is very unique to each community, kind of education sessions to do that myth busting that needs to take place, and to hear the stories of community members. Hear the concerns they have, the fears they have, and no question is unwelcomed. It's, where we're really learning from one another in this and supporting one another in this. So tremendous examples of partnership and engagement and learning together, and really, building on that trust that's been built through relationship. Thanks.
Thank you. And we'll conclude now in order to acknowledge everybody's availability, and that our teams have operational items to attend to. So I really appreciate all of the media respecting our media availability and using this as a way to get messaging out in an efficient way. So thank you very much for that. And thanks once again. And we're interested in hearing from you as to whether this is an effective media and whether we should continue doing this in future weeks. So with that, we'd ask you to fill out this brief poll, and once again, express our thanks. And lastly, thanks to the panel for your thorough answers. Bye for now.